Assalamualaikum.
Waalaikumsalam, Doktor.
Waalaikumsalam, Doktor.
Okay. All right. Okay, let's begin our session with Kitab Al-Fatihah. Okay, let me ask you something. If you can see, okay. Wait. Can you see my screen?
Yes, Doktor.
Huh?
Yes, Doktor.
Yes, Doktor.
Can you see just the slide or macam mana?
Nampak slide je.
Just satu slide ni kan? Ada nampak
satu.
ada nampak tepi-tepi dia lain tak?
Tak ada.
Ada, okay. Alright, so we'll continue where we stopped before. What is this? What is this?
Acronym aspiration.
Mechanical aspiration. Why mechanical aspiration?
Because of the
So air
trappings.
trappings. So air trappings, you can see air trappings there. And then basically you can see some air bronchograms as well. Wait, let me see. And there's some more setting. Okay. What is this?
Tension.
This is tension pneumothorax. Why tension pneumothorax? Because you can see air here. This is hyperlucency. Hyperlucency. The mediastinum is pushed, is herniated into the right side, and this is a chest drain. You can see this is the upper lobe, this is the middle lobe of the right lung. Okay, and as you can see, this is the ET tube. This is a PICC, long line. This is the NG tube. So if this sort of X-ray comes in your exam, you need to mention. So what you can see a hyperlucency area in the right lung field with herniation into the left mediastinum. It pushes the mediastinum towards the left. You can see the trachea, everything is deviated to the left, so it pushes to the left. And then you can see a chest drain, you can see ET tube inside too, you can see long line, you can see NG tube. So these are the things that you need to mention. Okay. This case, as I told you, this case has come out in one of your colleagues' exam recently, and it may come up again. And even before that, this same picture, because this is a very good picture from, it's not from Google lah, it's in the Radiopedia. It's a very good website for learning radiology. It's a very good resource, so it's available to be used. So that's why we use this. What is this? What is this?
Transient tachypnea in newborn.
So yes, this is TTN. So basically, this is almost normal picture, but you can see there's perihilar streakiness, perihilar opacity, perihilar streakiness there, and then you can see some fluid in the fissure. It's not that clear, but sometimes you may see much more clearer fluid in the fissure. What is this?
Normal chest X-ray with thymic tails.
Thymic sail sign.
Thymic sail.
So this is the normal chest X-ray with normal thymic sail sign. So this is the thymus. This is the normal thymus. Sometimes it gets bigger, sometimes it may be smaller, sometimes you can see on the left side as well. So this is the normal thymus. So do you need to be worried? Do you need to worry about this?
No need.
Not be worried. You should just ignore this. Okay. All right. What is this?
Boot shape heart.
Boot shaped heart. So typical in typical in TOF. So why this happened is because the right ventricle is at the inferior. Left ventricle is on the anterior or more left anterolateral. So that's why if left ventricular hypertrophy, you will see cardiomegaly. But right ventricular hypertrophy, you see boot shaped heart. So and in this sort of film with pulmonary stenosis, you will see oligo. You will see. You'll see. You will, so no, you will see. You won't see that much fluid in the lungs. Okay. All right. What is this? What is this?
Features of RDS with reticulonodular changes.
Yep. So this is reticulonodular changes for
Ground glass.
RDS, ground glass appearance. So what you see here is actually diffuse granular opacities, which is described as ground glass. And it is usually symmetrical. You can see some air bronchograms there. You can see some air bronchograms there. Can you see? Oh, I forgot to. I'm supposed to actually share this slide with you. Forgot. Next time remind me. Okay, fine. And then okay, all right. What is this? This is another X-ray. Not the same patient, but this is RDS as well. What is this?
Left congenital diaphragmatic hernia.
Left congenital diaphragmatic hernia. So these are bowel. Sometimes there may be even liver inside there, but usually on the right side. So left side liver tak ada. Okay, all right. What is this?
Pneumonia.
Tracheoesophageal fistula, esophageal atresia. So esophageal atresia with tracheoesophageal fistula. So why I say is esophageal atresia? Because the rice tube is reversed here. See, it doesn't go down. So rice tube should go inside the stomach. But if you pass the rice tube, it U-turns there. So this is a esophageal atresia. Why I say there is tracheoesophageal fistula? Because there are gas in the stomach. So without tracheoesophageal fistula, so apa maksud tracheoesophageal fistula? Maknanya trachea, esophagus here, it stops there. Dia ada blunt-ended esophagus. Trachea, it connects down, but down there is another connection to another part of the esophagus. So sebab itu air from the trachea gets into the stomach as well. That's why we can see gas pattern there. So this is tracheoesophageal fistula, but with esophageal atresia.
Sorry, Doctor, can I ask?
Yes.
If without the presence of the rice tube, can we know whether it is esophageal fistula or not?
No. That is why in newborns, if you do chest X-ray in newborns, you should put a rice tube in. So and then sometimes in patients with for example patients with whose mother has polyhydramnios. So esophageal atresia, one of the causes for polyhydramnios in mothers are esophageal atresia. So in mothers with polyhydramnios, you need to do chest X-ray, but you need to put the rice tube in. It is very difficult. So sometimes if you miss, usually esophageal atresia you don't usually miss lah, because if you miss, how can the baby feed? The esophagus dia tak sambung, so the baby cannot feed. So but sometimes you may miss this H type tracheoesophageal fistula. H type maknanya the esophagus is continuous, the trachea is continuous, but there is a connection. Macam H, letter H, kan? Connection between trachea and also the esophagus. So this is H type tracheoesophageal fistula. So sometimes you may miss. So what happens is dia akan jadi banyak the child will always get this aspiration, micro aspiration, come with aspiration pneumonia and all those things. So this is because tracheoesophageal fistula. Okay, clear. What is this? This is pneumonia lah, this side ada consolidation. Remember, if you comment on X-ray, you need to always comment about the tubes and everything. Okay. All right. Next, this is the video that we've seen last week. I'm not going to show this again. Oh, do you want to see again? Let's see. So, baby grant. So can you appreciate the sound? So the sound is when the baby closes his vocal cord, and dia close vocal cord, lepas tu dia tekan, and dia push, dia increase intrathoracic pressure. So what happens is the baby is trying to open up his airway, open up his alveolar and things. So this is grunting. So grunting is a sign of respiratory distress. And this is just to show this recession, subcostal and some intercostal recession as well. You can hear some grunting as well. Baby tu bunyi so that is grunting as well. Okay, so let's go to respiratory diseases of newborn. Okay, we've seen several of the common main respiratory diseases of newborn. Newborn actually is not that difficult. Neonates is it's not that difficult because the diagnosis is not that many. Yeah, usually, well, there are lots of diagnoses, but then the common diagnosis, the common diseases that we see in neonates are not that many. So in terms of respiratory disease of newborn, usually the cases that we see are those that I've discussed before, usually TTN, congenital pneumonia, RPS, and those that we've discussed before. Okay, so these are the objectives. Yep. Okay, so just to recap, so you need to remember when you look at neonates, you need to always look at the fetal lung development. So fetal lung development, by week 4, usually the laryngotracheal groove forms from the floor of the foregut, and then by week 5, the left and right lung buds push into the pericardio-peritoneal canals, where there's primordial of the pleural cavity. By week 6, there's descent of the heart and lungs into the thorax, and then the pleuroperitoneal foramen starts to close. This is by week 6. By week 5, you can see there's the groove is being formed, and then by week 6, it starts to descend into the intrathoracic cavity. And then by week 7, the lung buds divide into secondary and tertiary bronchi. By week 24, the bronchi divide 14 more times, and the respiratory bronchiole starts to develop. And by birth, there will be an additional 7 divisions of bronchi. When does the fetal lung completes development? A human, when does fetal lung completes development?
13 years of age.
Yes, up to 13 years of age, because it takes time. Sometimes our lung, before 13 years, is not fully developed yet. So that is why this is an ongoing process. Okay, fetal lung histology. So stage 1, by 5 to 17 weeks, there's pseudoglandular period where all the major elements of the lungs have formed, except for those involved in gaseous exchange. So only after 17 weeks where we have the development of the gaseous the lung cells where gaseous exchange occurs. Stage 2, the canaliculated period between 16 to 25 weeks where bronchi and terminal bronchioles increase in lumen size and the lung become vascularized. So this is when the tissues that are involved in gaseous exchange starts to develop. Stage 3, where the terminal sac period from 24 weeks onward, So more terminal sac develop and interface with capillaries lined with type 1 alveolar cells or pneumocytes. So also type 2 pneumocytes, where type 2 is the one that secretes the surfactant. So these are all starts usually starts from 24 weeks, 24 weeks onwards. So that is why, do you know, if a mother come in with okay, if you have a premature, how to say, okay, so if you have a pregnant lady come into the delivery room, do you know what is the age for what to say, what's the term, survival age? So at which age do we actually attend resuscitate baby and things? Which age? So
28 weeks.
if a mother comes in at 27 weeks, do you think should we resuscitate the baby?
I don't think so because alveoli does not develop yet at that age.
27 weeks.
Yes.
Okay. Who says we should resuscitate? Or everyone agrees with Fitria?
24 weeks, doctor, is the cutoff since the elaboration of surfactant starts there.
So Aklan thinks it's 24 weeks. You think it's 24 weeks. Anyone else? Okay, so basically it depends on the center, it depends on the country, it depends on the general, also depends on the locality of the hospital as well. So the point I'm saying is, if you take for example hospital HRPZ, Hospital Raja Perempuan Zainab 2 Kota Baru, so they take 27 week. Their cut-off point is 27 week in 800 grams. If the child is more than 27 weeks and more than 800 grams, only they will resuscitate. All less than that will be considered as either abortion or considered as early neonatal death. Those babies won't survive. If you look at UK, so UK takes 24 weeks. So UK takes 24 weeks. So those born 24 weeks and above, 24 plus 0 and above, they will resuscitate. Those 23 to 24 weeks, they will discuss. They will discuss with mother. If mother wants to resuscitate, they want to go more. Mother understands the associated complication. Then 23 to 24 weeks, they will assess the baby at birth. If the baby shows some signs of life, they will try to resuscitate, but not full resuscitation. Tak ada chest compression, there'll be no drugs. Tak ada bagi adrenaline, tak ada bagi atropine, tak ada bagi semua-semua tu. Dia cuma resuscitate, itu bed macam tu, tengok macam mana. Tapi kalau baby doesn't show any signs of life, they will not resuscitate. They 23 to 24 weeks. But now UK, before I came back, I think late last year, UK starts to discuss about 22 to 23 weeks. If you look at other countries such as Canada or Japan, so Canada and Japan and some other Nordic countries, they are more advanced a bit because of their numbers and their system. So they have already been resuscitating 22 weeks and above. So their cutoff point is 22 weeks. Okay, I said about Canada, UK, I've said about Japan. How about Malaysia? Malaysia, I've only mentioned Hospital Raja Perempuan Zainab Kota Baru. It takes 27 weeks and 800 grams weight of the baby. How about generally in Malaysia? So generally in Malaysia, if you look at the PSM punya paper, or generally in Malaysia we take 25 weeks. Generally in Malaysia, we resuscitated babies more than 25 weeks and 500 grams. Those less than, so in Malaysia, our cutoff point is 25 weeks and 500 grams. So babies less than 500 grams, we do not resuscitate. We allow for comfort care. So baby will die, but baby will die with comfort. So 25 weeks and 500 grams in Malaysia. 24 to 25, we do like UK, we do by discussion. So we discuss with mother, we tell the mother what are the complications of having extreme premature babies, and we see how things goes. If the baby doesn't show any signs of life, mata pun tak buka lagi, mata opening of the eyes ni is actually good parameter of maturity. Kalau mata pun tak boleh buka lagi, so it shows that baby is extremely premature. Lots of bruises in the body, so baby is extremely premature. So those less than 25 week we don't resuscitate. But 24 to 25 week in Malaysia, it depends on discussion, it depends on the baby's general condition. Kenapa kita ada plus minus 1 or 2 weeks? Because sometimes dating scan may not be correct. Sometimes dia ada plus 1 or 2 weeks plus minus. Sebab tu sometimes kalau kita ada 25 weeks, sometimes the baby is actually maybe a bit more or a bit less than that. Faham? Clear? Okay, so in Malaysia sama juga dengan UIA. We were thinking, so at which age should we come and resuscitate babies? So we were keen to take 24 weeks as per global worldwide semua 24 weeks, because 24 weeks is when your terminal sac starts to develop, your alveolar cells start to develop, where your pneumocytes, usually type 2 pneumocytes, starts to secrete surfactant 24 weeks. So we prefer to take 24 weeks, but then the issue is other hospitals in Malaysia, they take 25 weeks. So then we decided to go according to the national guideline, which is still 25 weeks and 500 grams. Okay, clear. So stage 4 is the late fetal period, where the alveolar period where 95% of mature alveoli starts to develop. Alveoli starts to develop, but 95% of mature alveoli develop after birth. A newborn has only 1/6 to 1/8 of the adult number of alveoli. So this will continue to develop until you're 13 years of age. That is why things like smoking and things is very problematic for children. Okay, we've mentioned before respiratory distress at birth. If a child is born and we noted that the child has respiratory distress, so it can be respiratory cause and it can be non-respiratory cause. What are the non-respiratory causes of a child being distressed? So a baby can be hypothermic because newborn babies, they have comparatively larger body surface area. It's not that their body surface is bigger than adults, but comparatively they have larger body surface area. So there's more areas for heat loss. So they can go to hypothermia, and hypothermia itself can cause baby to be in respiratory distress. And furthermore, they are born with lots of vernix, they are born with lots of fluid on their body. Ada banyak air dalam dekat kulit dia. So what happens? These fluids, what happens with the fluids? The fluids will evaporate. So this process of evaporation from water on the skin changes to vapor. This process of water changing to vapor, actually, what is the product? The product is loss of heat. So the product is loss of heat. So more hypothermia can happen. This is the same thing like you doing tepid sponging. So tepid sponging is not that you put water, bukan you celup air, bukan celup budak tu dalam air ataupun jelun budak tu dalam air ataupun you letak air basah lencun. No, the concept of tepid sponging is you put some drops of water on the skin, and then when the water evaporates, water changes from liquid changes to vapor. This biochemical process causes the body to lose heat. So this is the mechanism. Also hyperthermia as well. Hyperthermia can also cause a baby to be tachypneic and seems to be in respiratory distress. Hypovolemia, of course. Why hypovolemia can cause respiratory distress? Because of the the stimulation of the cardiorespiratory center and causing the child to be tachypneic as well. Hypotension, wrong spelling there. Hypoglycemia as well can cause child to be tachypneic. Anemia as well can cause child to be tachypneic, and polycythemia. Okay, the other problem that we can see, as mentioned before, is transient tachypnea of newborn, surfactant deficiency, which is RDS, or the other term is hyaline membrane disease. And also meconium aspiration syndrome, pneumonia, sepsis, and also pneumothorax and other sort of air leaks. Pneumothorax, what else? What's the term? Pneumomediastinum. So all these are air leaks. So respiratory causes, it can be congenital abnormalities of the lung, congenital heart disease, congenital diaphragmatic hernia, CCAM, congenital cystic adenoma malformation, where there's lots of cysts in the lungs. It can be tracheal abnormalities, tracheal fistula, esophageal atresia, or it can be pulmonary hypoplasia, where the lung is not really formed well. So the problem with pulmonary hypoplasia is it will be very difficult to manage because the lungs are not well formed. So if the lungs are not well formed, it's very difficult. The child will have chronic lung disease. Very difficult to manage. Pulmonary hypoplasia. Sometimes apa symptom dia? So those patient presenting with oligohydramnios. So those patient, those mother who has oligohydramnios, one of the problem that we should always think of is pulmonary hypoplasia. And then PPHN, pulmonary hemorrhage are among the other problem. What is persistent pulmonary hypertension of newborn? What is PPHN? Anyone can suggest?
Can I try, Doctor?
Yes.
It's like a during fetal punya period, there is a high hypertension in the pulmonary, but as you are born, it's supposed to go down. But due to some causes such as hypoxemia or acidosis, it can cause the vasculature to be hypertensive. So,
okay, so basically, in fetal life, when the baby is inside mother's uterus, so what happens is they don't use the lung, and the lung is filled by fluids. The lung is filled by fluids. The lung is filled by fluids. There's compression on the blood vessels, which causes the compression on the cell tissues, isn't it? So this compression causes increase in the pulmonary pressure. And you know what is connected to the baby is the placenta, and placenta is a very low is a low pressure punya circulation. So placenta reduces the total venous resistance. So presence of placenta, when your vessel is connected to the placenta, it reduces the total pulmonary venous resistance, total peripheral venous resistance by connecting it to the placenta. So it reduces the total systemic blood pressure. So systemic blood pressure is lower as compared to pulmonary blood pressure. So what happens is blood is shunted from going into the lung because there's high blood pressure. It doesn't go into the lung. It goes into the systemic circulation via there's two shunts, isn't it? Where are the shunts? I thought I did the discussion with you. Yeah.
Yes, Doctor.
Yes.
Just few days before we were quarantined.
Yes.
Ovary and ductus arteriosus.
Yes, ductus arteriosus and
Foramen ovale.
Foramen ovale.
foramen ovale. So they shunt through the interatrial, which is the foramen ovale, and also between the aorta and also the pulmonary artery, which is the ductus arteriosus. So these are the two shunts. So what happens when the child cries? When the child is being born, first there are several mechanisms. First is compression of the chest. Kan, masa dia nak keluar kan, kalau dia keluar through vaginal delivery, compression of the chest causes the body pushes out fluid from the lung, it goes outside. So that's one thing. That is why if a child is born by cesarean section, there is higher risk of TTN. Why? Because there's not the fluid is not excreted out by the compression of the chest. That's one thing. Second, apa lagi tadi? The child starts to cry kan? Dia nangis.
Yes,
Bila dia cry apa? Expansion of the chest. So expansion of the chest, you reduce the intrathoracic pressure. What happens? Satu, you expand kan? Bila you reduce intrathoracic pressure, what happens? The fluid will start to be absorbed into the lymphatics. the fluid will start to be absorbed into the lymphatic because of the reduce in the intrathoracic pressure. Kan, you expand the lung, reduce intrathoracic pressure, fluid absorb into the lymphatics. Okay, and then what happened? Dia air start masuk dalam airway. Air from outside with oxygen start masuk dalam airway, start masuk into your alveolar. What happens? Your PaO2 will increase. PaO2 is a good, oxygen is a good vasodilator. Oxygen is a good vasodilator, but oxygen as well, oxygen acts as well. So oxygen akan, bila dia vasodilator, dia akan, bila dia vasodilate, what happens? Reduce pulmonary blood pressure. Also, oxygen as well will act on the ductus arteriosus as well. So oxygen will cause the ductus arteriosus to close. Oxygen will cause the ductus arteriosus to close. So net effect is, and then kita cut pula placenta. Bila kita cut placenta, you will lose the very low pressure punya circulation, serial circulation kan. You belajar elektrik kan, macam mana kalau serial dengan apa nama circulation tu kan. So low, very low pressure punya, low resistant, ultra low resistant punya circulation placenta ni, bila you buang, what happens? You automatically you increase the total resistance, total peripheral systemic resistance is increase because you lose this placenta punya circulation ni. So what happens? Your pulmonary blood pressure will reduce, your systemic blood pressure will increase. So that is why sebab tu blood daripada heart dia pump into your lungs, dia dekat saja, they don't need very high blood pressure. Kan? And then your lung is small, but your body is big, so left ventricle needs to pump strong into the whole body. Kan? So kalau pulmonary pressure is high, so it will be difficult. That's why you have right ventricular failure, right-sided heart failure. Okay, so persistent pulmonary hypertension of newborn ni, it can be idiopathic, it can be because of meconium aspiration, it can be because of pulmonary hypoplasia, it can be because of so many other problems. So, but this is very difficult because why? Because if your right-sided, if your pulmonary pressure is high, there will be shunting, right to left shunt. So usually, kalau ada VSD, ventricular septal defect, the shunt is left to right ke right to left?
Left to right.
The shunt will be left to right. Kenapa left to right?
The pressure in the left ventricle.
Because of pressure gradient. So pressure gradient in the left side, systemic side is always higher than the right side. That's left to right. Kalau VSD, dia jadi right to left. What is the problem with that? Fitria? Kalau VSD, if you have a child with VSD, lepas tu you buat scan, you nampak dia punya shunting tu right to left. What is that?
I think it's dah jadi Eisenmenger syndrome.
Yes, very true. Bagus. So if you have VSD and then you have right to left shunt, so there is Eisenmenger. Eisenmenger is a irreversible pulmonary hypertension. So dia jadi right to left shunt. Bila right to left shunt, this is where you will see cyanosis. This is where you will see cyanosis because blood right tu dia tak sempat lagi nak di oxygenated. So this is why you have cyanosis. Okay, alright. So like that, babies with persistent pulmonary hypertension of newborn, you will see that they are cyanosed. Okay, I have one more thing to ask. Okay, siapa boleh jawab? If you suspect the child to have persistent pulmonary hypertension of newborn, there is one bedside test that you can do, bedside assessment that you can do to know that, okay, oh, this is PPHN, this is pulmonary hypertension of newborn. What can you do? A bedside assessment.
Hyperoxia test, Doctor.
Hyperoxia test. Okay, macam mana? How do you do hyperoxia test?
we give by that this one to differentiate failure, whether it's pulmonary cause or cardiac cause.
No,
We give
hyperoxia test. Okay, fine. Teruskan. I'll tell you why you are wrong lah.
we give 100% oxygen for 10 to for 10 minutes, and then we expect improvement if it's pulmonary cause, where it is supposed to be more than I think 60 PaO2, and SpO2 improved by, I'm not sure about the numbers, and vice versa.
Okay, hyperoxic test is used to differentiate between pulmonary causes of cyanosis or poor oxygen, poor saturation, to differentiate between pulmonary cause and cardiac cause. So basically like cyanotic congenital heart disease. So if the child is being persistently saturation is not that good, so you're not sure is it pulmonary or is it cardiac cause. So you do hyperoxic test. So because if you do hyperoxic test, if the problem is actually cardiac cause like TOF or other cyanotic congenital heart disease, even if you give 100% oxygen, the saturation, the PaO2 will still remain low. But if the problem is lung, when you give 100% oxygen, the SpO2 will improve, the PaO2 will improve. So this is to differentiate between pulmonary cause and also cyanotic congenital heart disease cause, not for PPHN. Because in PPHN, sometimes even if you give 100% oxygen, they will increase. Okay. What else can we do? There's a simple bedside assessment, bedside test that you can do to show you that this is actually probably PPHN.
I think it's about blood pressure measurement.
Nope. Iaitu blood pressure measurement for limb BP is useful for coarctation of aorta. So coarctation of aorta sebab di coarct tu dekat aorta, so you will see blood pressure in the lower limb will be lower than blood pressure in the upper limbs. Sebab dia coarct dia sempit. So upper limb sebelum dia punya coarctation tu upper limb punya blood pressure will be high. Tapi lower sebab dah ada coarct dia sempit, so blood pressure in lower limbs will be low. Okay. It's something to do with SpO2.
ABG doktor.
ABG tak berkaitan dengan SpO2. SpO2. So what happens is you compare between, okay, I'm giving a clue. I still want you to think.
And preductal.
Preductal and postductal SpO2. You will see difference between preductal and postductal SpO2. Kenapa ya?
Not sure.
Okay, so look at the issues. Satu, okay. So kalau preductal ni mana preductal? Where is preductal?
Before the
duct lah. Okay.
first
So before the duct ni mana? Where?
arch of aorta.
Yes, dekat arch of aorta tu kat situ. But where? Huh?
Right.
Okay, yes, radial artery. Yes. But which side? So it's right upper limb. So right upper limb is preductal. Right upper limb is preductal. Left upper limb and lower limbs are all postductal. Sebab the supply is before the duct. Sama juga bukan setakat right upper limb, juga your ears apa semua ni kan. They before the duct. So these are all preductal. Left upper limb and semua bahagian lain, those are postductal. So kenapa duct is important? Because the increase in pressure is in the pulmonary. Increase pulmonary blood pressure, systemic blood pressure naik juga, tapi pulmonary blood pressure ni naik dan dia persistently high. So what happens is right to left shunt. In this sort of patient, I told you before, in newborn babies, the ductus arteriosus takes minimum of 5 to 7 days to close. In premature babies, extreme premature babies, they take longer to close. In some babies, they don't close. And so, bila duct is still open, what happens? Bila ada pulmonary hypertension, there will be right to left shunt across the across the duct lah, across the duct. Kan? So this deoxygenated blood from the pulmonary artery, belum sampai lung lagi, from the pulmonary artery goes through the duct into the aorta. Nampak? So sebab itu if you see postductal akan jadi lebih low dia punya SpO2. Kan? Yang preductal okey lah sebab ni dia tak dapat yang deoxygenated blood tu, dia dapat blood yang dah oxygenated, high oxygenated blood. It's good kalau I can draw, tak boleh draw lah. I need to buy something yang boleh draw.
Zoom boleh tak?
Zoom boleh draw, susah nak draw dengan jari. Macam mana ya? Boleh draw, annotate.
Kalau draw on PowerPoint boleh?
Dia buat share baru.
Tak apalah, next time lah. I think it's good kalau kita boleh buat session about understanding pathophysiology of cardiac problems, pathophysiology of some of the respiratory problems, how basically difference between murmurs and stridor. Or did we have discussion about this before? Pernah kan dalam group year 5 semua sekali? I think we did have kan? Ada kan? Ramai-ramai kan?
Waktu fine.
Lupa dah. Okay, fine. Next. So, mana ni nak buat ni? Macam mana nak buat ni? Cuba nak keluar balik ni. Okay, so the easiest test to assess whether the baby has pulmonary hypertension of newborn, PPHN ke tak, is doing the checking the preductal and postductal saturation. Okay. What do you need to know to figure out the cause? So basically we need to look at the maternal history, if there's any risk factor, gestational age of the infant. So you know things like, for example, maternal history ni, contohnya macam GDM, diabetes mellitus, gestational diabetes mellitus. Gestational diabetes mellitus is a risk for RDS by itself, because this high blood sugar is the problem is it acts on the surfactant production. So gestation diabetes mellitus is a problem, is a cause for is a risk for RDS in babies, surfactant deficiency in babies. Also meconium aspiration, for example, meconium aspiration is a risk for meconium aspiration syndrome. Meconium stain amniotic fluid, a mother with meconium, there is a risk for meconium aspiration syndrome, MAS. Satu. Yang kedua juga, meconium is toxic to your surfactant. Meconium renders your surfactant inactivated. Meconium inactivates the surfactant. So that is why sometimes in children, in babies with severe meconium aspiration syndrome, for example, they may present almost like RDS punya features because surfactant is inactivated by the meconium. So sebab tu kadang-kadang kita boleh buat surfactant lavage. And then kita push surfactant inside into their alveolar. So this is something that we can do. So maternal history is very, very important. Sama juga I've told you before, things like polyhydramnios. So mothers with polyhydramnios, there is a high risk that the child has esophageal atresia. So you need to do chest X-ray afterwards. A mother with oligohydramnios. Oligohydramnios is associated with apa? I've said before. Oligohydramnios associated with
Pulmonary hypoplasia.
pulmonary hypoplasia. Yes, because your lung won't develop well. Ini satu study when I was in UK, one of the papers that I helped to publish is a study about Fetal. So Fetal is what is Fetal? Fetal ni what happens is, okay, if you compare dengan, if you tengok Malaysia, you pernah tengok tak babies with congenital diaphragmatic hernia? Pernah tengok? Kita tak banyak case lagi lah. So in Malaysia, congenital diaphragmatic hernia ni biasanya diagnose postnatal, lepas deliver. Tapi in countries like UK, even in India, more than 90% are diagnosed antenatal. So antenatal they diagnose, oh, this ada congenital diaphragmatic hernia. So what happens is, so the idea, so congenital diaphragmatic hernia is associated with pulmonary hypoplasia. Sebab lung dia tak develop well, lepas tu the other side of the lung is pushed by the by the bowel apa semua, so dia tak develop well sebab compression effect. So the idea is bila dia diagnose children yang ada moderate to severe CDH in utero, apa dia buat within the first trimester, maknanya within probably 10 week of gestation macam tu, dia akan buat through dia macam amniocentesis, maknanya through mother punya tummy tu, dia intubate, dia letak balloon dekat trachea baby. Baby tu dalam perut, dia letak balloon dekat trachea of the fetus. So balloon. So what happens bila ada balloon tu akan maintainkan fluid dalam lung. Dia akan push, increasekan pressure dalam fluid. Tisu dalam lung ni akan sentiasa produce fluid. Tapi bila dia letak obstruction kat situ, fluid tu akan banyak, increase pressure, more extension. So dia akan promote development of the lung. So reduce risk of pulmonary hypoplasia. So that is the study, and then we see that actually this balloon, fetal balloon ni is actually quite useful lah. And less risk of pulmonary hypoplasia. So benda-benda macam ni kita kena tahu. Gestational age, obviously, preterm baby there is higher risk for RDS dan sebagainya. Amniotic fluid color, odor, volume. So kalau amniotic fluid tu is foul smelling, what do you think? Foul smelling like what? Congenital amnionitis, penyakit mak lah. Penyakit baby will be congenital pneumonia. Congenital pneumonia. Foul smelling like what? You need to always treat the baby. The baby maybe become sepsis, septic. The baby may have congenital pneumonia. So color of the amniotic fluid, odor of the color ni, sometimes they may be bloody. So kalau amniotic fluid dia bloody, so you know that probably the child have anemia dan sebagainya. And then odor and then volume of the amniotic fluid, oligo, polyhydramnios, those have risk associated. Intrapartum history, of course you need to know kalau ada maternal pyrexia, mother tu ada fever, even mother ada dengue, mother ada I've seen varicella encephalitis in newborn, congenital varicella. Baby tu dapat HIE sebab congenital varicella. So chickenpox is a problem. So chickenpox, baby, if mother is actually having chickenpox, it can spread to the baby in utero and also after delivery. So COVID and other diseases as well. So we need to know the intrapartum history. Clinical presentation of the baby and assessment at birth, you can know, and then chest X-ray as well. We've seen several chest X-ray, and then the lab evaluations, which we'll see lah. Okay, and then how do they present respiratory assessment? Of course, respiratory. What is the normal respiratory rate of? What is your respiratory rate? Normal.
16 to 20.
How about respiratory rate for newborn?
Newborn
More than
50%.
More than 100?
50.
Huh?
50.
50.
Respiratory.
Newborn respiratory rate is usually 40 to 60. So up to 60. 60 is the cutoff point. So 60 is the cutoff point. So they may breathe 60 breath per minute. So this is for newborn. So anything more than 60, so probably there is respiratory distress. And then quality as well, quality of the breathing. Is it shallow breathing? Is it deep breathing with deep recessions? Shallow breathing, meaning there's some respiratory depression, for example. The baby may be premature, so sometimes they may be shallow breathing. So these are all signs of respiratory distress. Nasal flaring, kebang kencuk hidung. So nasal flaring is also a good sign of respiratory distress. Grunting, as we've shown before, bunyi itu. The child trying to increase the intrathoracic pressure untuk open up the lung, kurangkan fluid dalam lung sebab bila dia increase intrathoracic pressure tu dia akan push fluid into the interstitium and goes into the lymphatics kan. And then this is grunting, and then retraction, chest retraction, and then breath sound. You may hear consolidation, you may hear crepitations, crackles, and things. And also kalau pneumothorax, you can percussion may be dull on percussion, tapi newborn is quite difficult lah for you to do percussion. Obviously, you cannot do vocal resonance, but you can appreciate vocal parameter sometimes in newborn, even kalau ada pneumothorax. And then the color of the baby, they may be pink, dusky, pale, mottled skin. And then you look at the heart rate. You know, if the baby is tachypneic, the heart rate is usually increased as well. You can look at the pulses, distal versus central pulses, and then perfusion. You look at perfusion, clinical presentation. Okay, sometimes children with whether there's any syndromic features, flat nasal bridge, simian crease, single palmar crease, recessed chin, low set ears. So sometimes these are features of Down syndrome. Down syndrome is also associated with PPHN. Down syndrome is associated with PPHN. And then are there any other abnormalities, gastroschisis, perforated anal? So sometimes these all have they are associated with lung problems as well. Whether there is hypotonia or hypertonia as well. So and then things like, have you heard of Ondine curse? So there ada satu disease. Disease ni is about central hypoventilation syndrome. Central hypoventilation syndrome ni is a neurological punya problem where the child will hypoventilate. The breathing will be short and shallow and then become apneic. So this is central hypoventilation syndrome or Ondine curse. O-N-D-I-N-E curse. C-U-R-S-E, Ondine curse. So sometimes they may have hypotonia as well. So hypotonia, central hypotonia is associated with laryngomalacia. So the child may have problem with the airway as well. So respiratory distress is not just about the lungs, it may also be because of the upper airway, kan? So bila upper airway obstruction, dia akan jadi distress jugalah, contohnya laryngomalacia. Sama ada proper laryngomalacia or because of central hypotonia. Down syndrome for example, neck control dia very weak. Bukan setakat neck, maknanya central tone dia is low. Bila central tone dia low, dia punya epiglottis dia akan close dia punya vocal cord and causing respiratory distress. Kalau macam chin, small chin dia kecil kan, dia pun boleh obstruct airway juga. Apa contoh yang ada very small chin ni?
Di George syndrome.
Di George syndrome lagi?
Micrognathia.
Micrognathia lagi?
Marfan.
I forgot the term.
Kalau Down syndrome ada tak? Because dia macam
Down syndrome pun boleh ada micrognathia. Down syndrome boleh ada central hypotonia, boleh ada micrognathia. Dia boleh ada glossoptosis. Dia ada glossoptosis apa semua. Macroglossia. Pierre Robin sequence. Ada nggak Pierre Robin? Pierre tu nama French name lah, Pierre. P-I-E-R-R-E. And then dash, pasal seorang lagi doktor nama Robin, orang panggil Pierre Robin. Pierre Robin sequence. So Pierre Robin sequence, when the child has micrognathia, glossoptosis, Pierre Robin sequence ni is very difficult sebab nak intubate dia very difficult. Very difficult. Sebab dia punya airway dia very very small. Nak intubate very difficult. I've seen very severe Pierre Robin. And then all these are the problems. Let's see. Okay, if you do X-ray, obviously you need to look at all the structures, the ribs, vertebra, liver, stomach, intestine, and whatnot. Lungs, you need to look at the lung volume. Pulmonary hypoplasia, usually the lung volume will reduce. They are the bell-shaped heart. Yeah. Lung expansion. So kalau MAS, RDS, sometimes you may see the lung will be hyperinflated. Give me 1 second. Hello? Sorry. Okay, sorry, because they have a problem with an extreme premature. Okay, all right. So X-ray, you need to look at all these things as I mentioned before. Lab values, you look at full blood count. Kenapa nak tengok full blood count? Sebab kalau congenital infection, you can see WBC to be raised lah, ataupun WBC will be very low. CRP, CRP is another good parameter as well. CRP is an inflammatory marker. Bila ada infection, there will be inflammation. Bila ada inflammation, CRP will rise. Bukan setakat itu, MAS also can cause CRP to be rise, electrolytes and whatnot. Okay, we've seen this, we've discussed about this. TTN, as mentioned before, this is the commonest diagnosis of respiratory distress in the newborn. So usually, transient tachypnea of newborn is because of the ineffective clearance of amniotic fluid from the lung with delivery, usually within 4 hours saja. It shouldn't go beyond 4 hours. Kalau dia beyond 4 hours ni, most likely it's not transient tachypnea of newborn. More common with cesarean section, ada maternal analgesia dan sebagainya. And then tachypnea usually 60 to up to 150, ada nasal flaring, all the signs of respiratory distress. And then X-ray, you can see increased perihylar, punya streakiness, hyperinflation, fluid in the fissure. Because CVC normal sebab tak ada infection lah. It is just a transient punya problem. X-ray before, surfactant deficiency or hyaline membrane disease, mostly associated with premature infant. So problem is decrease surfactant production. Because why? Sebab surfactant tak sempat nak produce lagi, kan? So decrease surfactant production. And then history usually is premature baby, mother with diabetes and whatnot. And then all this may also cause with RDS problem as well. They may present with features of respiratory distress. X-ray, we can see the reticulogranular pattern or ground glass appearance as we've discussed before. You can see some air bronchogram. They may be bell-shaped as well. You can see some air leak, macam tapi small cystic changes or PIE changes. And then you can see atelectasis, lots of heart border. This will become white, and then white out, very severe punya RDS. Example of RDS, we've seen two better X-ray before. And then what else? Lab result, treatment is basically we may give surfactant. So surfactant ni ada isu juga, surfactant. Sebab what do you know about surfactant? How many types of surfactant kita ada?
There are 2 types of surfactant, bovine and porcine.
Dia ada satu lagi, dia ada sintetik punya lah. Tapi sintetik punya it's not as good as bovine or porcine punya. So the issue is porcine kan. So kalau kita tengok dekat few hospital, dia guna Survanta. Survanta is Poractin Alpha, which is porcine punya base. Company brand ni nama Survanta. So Survanta is Poractin Alpha. It's a very good drug. It's a very good drug. Tapi isunya adalah dia porcine. Tapi dia ada alternate dia, macam kita kat UIA kita guna calfactant, kita guna Infaserve. So Infaserve, HDA pun dah start guna Infaserve. So Infaserve is a calfactant. So surfactant from calf, daripada lembu. Tapi is it halal? Halal ke?
Alah, istihalah.
So nak kata halal, satu isunya adalah beza dia dengan poractin is just different animal, but they are not, bukan sembelih kan. Dia tidak mengalami proses sembelihan itu. So dia bukan satu benda yang kita kata halal. Tapi kita kena ingat dia ada beberapa konsep lah. Satunya qawaid fiqhiyah yang kita guna. First adalah ad-darurah tubihul mahdzurah. Darurah, situation where there is darurah permits certain things that are even haram. So ad-darurah tubihul mahdzurah. But we need to remember ad-darurah tu tuqaddar bi qadariha. Darurah tu, kebenaran disebabkan darurah itu dia ada limitation. The limitation is with the dia ada qadar dia based on the darurah itself. Sebab itu you tak boleh bagi surfactant to everyone. All babies kita bagi surfactant. Tak boleh. Sebab ad-darurah tuqaddar bi qadariha. Itu first concept. Secondly is you go towards istihalah. So istihalah is when the product is changed from the from the initial punya ni, dia dah change. Tapi for surfactant it doesn't change because it is still surfactant. So istihalah is not actually used. You boleh guna juga konsep istihlak. Istihlak ni contohnya macam dua kullah kan. So najis masuk dalam air yang dua kullah, dia jadi bersih. Tapi sama juga surfactant punya isu dia tak terpakai sebab it is still there. But what we can do is look at the ad-darurah tubihul mahzurah. And ad-darurah tubihul mahzurah. So this is the concept that we need to know. Meconium aspiration syndrome, so mostly found in post-date infants more than 40 weeks. Sebab apa? Sebab kenapa baby pass meconium? Is it normal for a baby to pass meconium?
Distress and also maturation of gut.
Okay, they pass meconium in utero because they are distressed, they are stressed. Bila dia stress, dia pass meconium. So some ada because of their post-date, there are some element of placental insufficiency, they are hypoxic. So when they are hypoxic, when they are stressed, they pass meconium. Okay, kita baru separuh ni, banyaknya mungkin aku cerita ni. So next is, so you need to know the history, prenatal care of the mother, respiratory assessment as well as usual. So X-ray, as mentioned before, there may be increased epidiameter, hyperinflation, you can see atelectasis, you can see pneumothorax, you can see air trappings, air bronchogram, semua ni air trapping, blah 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 kat sini, these are all air trappings. And then congenital pneumonia, sepsis as well. So congenital pneumonia, intrapartum pneumonia, postnatal pneumonia, most often seen in mothers with chorioamnionitis, prematurity, because premature babies they are immunodeficient. Kenapa dia immunodeficient? Sebab your immunoglobulin starts to cross the placenta from 20 weeks onward. And so before that, immunoglobulin from mother doesn't cross placenta. So baby won't have enough protection. So you need to get thorough history. Okay, causes as mentioned before, assessment as this, X-ray, you can see patchy consolidation, you can see some diffuse granular pattern, you can see trichomes, you can see consolidation punya pattern lah. These are some X-rays. Air leaks, pneumothorax, so you need to know as well. So this is another X-ray of a pneumothorax. So if you do lateral decubitus, you can see this is the lung field, this hyperlucent area is where your pneumothorax is. This is pneumopericardium. So air is in the pericardium. So this is another problem. You need to drain this. So they will compress the heart. Okay, and then you may other things are such as congenital heart disease, diaphragmatic hernia as mentioned before, CCAM, tracheal abnormalities, severe tertiary pulmonary hypoplasia. Let us see congenital heart disease. So we're not going to go in that. Do we have X-ray? So CDH is where the bowel goes into the thorax. So because there's defect there in the diaphragm, so bowel content goes inside the thorax and cause compression, cause lots of problem. CCAM is where you have cystic changes. So this is CDH, ada gambar CCAM tak? CCAM is basically cystic changes and cystic adenomatoid changes in the lungs. PPHN we've discussed. So this is the ultra low resistance circulation in the placenta. Okay lah, I think that's all lah. So this is cystic hygroma. This is one of the from your branchial formation. Not brachial, branchial formation. So the cysts form from there and usually quite big. I've seen very big cystic hygroma. So the problem with cystic hygroma is it may cause compression to the trachea, to the trachea. So this is cystic hygroma. This is among congenital malformation. Tracheoesophageal fistula. This is the H type. This is the one I've told you before. This is H type. Sometimes kita boleh miss H type. This is tracheoesophageal fistula with esophageal atresia. Esophageal atresia, tracheoesophageal fistula. So ni yang macam tadi tu. Masuk rice tube pusing kat sini. Tapi dekat stomach dia ada air sebab ada connection between trachea and distal part of the esophagus. Other airway abnormalities, you may have patients with subglottic stenosis, webs, atresia, tumors, and things. All this can cause a vascular ring. But what is vascular ring? So vascular ring is, you know, your pulmonary vein, dia ada 4 kan? So sometimes this vein or even your aorta can go round your trachea. So sepatutnya dia duduk depan ke belakang. Sepatutnya duduk depan trachea kan. Sometimes they may go round, they may form a ring on your trachea. So bila they form a ring on your trachea, it compresses your trachea as well and cause respiratory distress. You may have stridor because of vascular ring. Sebab tu kalau ada stridor, you kena buat echo lah, just to make sure that you don't have any vascular ring. Okay, I think that's all. Okay, I think that's all. I'm going to give you these slides. You can read lah. Any question?
Doctor, I would like to ask.
Yep.
Regarding the backside test that you mentioned just now for PPHN, we take the oxygen saturation from the preductal and postductal. So the preductal one, we take it from the radial artery. Okay.
No. Bila you buat SpO2, where do you check the SpO2? So SpO2, dia bukan SaO2, dia SpO2. So you check the cutaneous lah. Maknanya you check dekat finger kan, you check macam pulse biasa. So you are checking the capillary punya perfusion kan. SpO2, you are checking the color of the capillary. Basically capillary, you're looking at capillary. You're not looking at arteries. You're not looking at, sebab tu dia bukan SaO2, dia bukan SvO2, dia SpO2, pulse capillary. So you're looking at the color of the capillary. So you put at fingers lah, fingers. In newborn babies, dia punya bone dia tak besar. Dia punya skin pun tak tebal. So you can even do at the wrist. So you letak monitor tu dekat wrist, you still can read. You letak kat jari. So just preductal is on the right, postductal is on the left and other part of the body. Sometimes you punya right side ni tak boleh buat ke apa, you boleh buat dekat earlobe ni. You boleh letak probe dekat earlobe. So earlobe is still preductal lah. Sebab goes before the ductus arteriosus. Okay. Any other questions? Clear? Yep. Yep. Yes. Why? Because you guys got the connection. We did some session about ventilatory setting with Dr. Ismail. If you guys have that, that's a bit high level lah. But we discussed several things. Among the things is we discussed about how oxygen is a free radical. So oxygen is a free radical. Oxygen itself can cause bronchopulmonary dysplasia, chronic lung disease because of high oxygen. So when you look at newborn babies, especially premature babies, what do you think is the level of the PaO2 and PvO2 in them, and the PaCO2 in them in newborn babies? PaO2 and PaCO2 in newborn babies, especially premature babies. Will they be higher or lower? Which one will be higher? Okay, Fine. I rephrase my question. If you assess in adult, Aklan janganlah unmute, janganlah mute, unmute dulu. Okay. So in adults, if you do your PaO2, what will be your normal PaO2? Okay, around 80. So you expect 80 PaO2. PaCO2, 35 to 45. That is normal in adults. Okay. How about your venous? In your venous circulation, your PVO2, will it be high? Okay. How low? So usually up to 60 lah, lebih kurang. 40 to 60 PVO2. How about your CO2? Venous. PVCO2. So obviously your CO2 will be higher lah in venous, kan? So it will be higher. It will be up to 60 like that in PVCO2 as well. Okay. So next question is, where does a fetus, dia dapat blood daripada mana? Dia dapat oksigen, dapat vein, dia dapat carbon dioxide, the gases dia dapat daripada mana? Fetal dapat daripada placenta, kan? Dapat daripada placenta. Placenta dapat daripada mana? So there's a mixture from maternal punya venous circulation and arterial circulation, but mainly is from the maternal venous circulation. So the amount of oxygen that a baby gets inside the uterus is low because it's relatively sama dengan mother punya venous punya circulation. Faham? Maknanya the oxygen level yang baby tu dapat masa in utero is low daripada mother. Dia punya carbon dioxide level yang baby dapat in utero is high sebab dia dapat daripada mother almost venous punya circulation. Faham? So sebab itu that is why in fetus and also in newborn dia ada fetal hemoglobin HbF ni. So HbF has higher oxygen. Dia higher ke lower? Dia lower oxygen affinity. Dia senang lagi nak release. Or is it I'm also confused? So basically HbF helps for this baby because oxygen dia low, so, higher oxygen affinity. HbF has higher oxygen affinity. So oxygen level dia low, so dia nak capture more oxygen. Kan? So this is the difference. So bila in this newborn, especially premature babies, they are used to higher carbon dioxide level. So they don't actually need lots of oxygen, and they are okay with higher level of and they are okay with higher levels of CO2 as compared to more term babies. So we usually accept permissive hypercapnia, permissive hypercarbia, as long as there is no acidosis. If you do blood gas, as long as the pH is more than 7.25, and that's okay. Okay. Any other question? Okay, I think we should stop now because I have another meeting at 11, which I need to prepare a bit. Okay, I hope you guys get a general idea about common respiratory diseases in newborn, especially those that you need to know: TTN, congenital pneumonia, MAS, pneumothorax, RDS, deformity hernia. So these are things that can come up and have come up several times in OSCE especially. It has come up in PMP as well. So, but you won't get it for clinical exam, obviously. So clinical exam, nothing about neonates, but you can get in theory exam. Okay, all right. Aku qauli hadza fastaghfirullahalazim li wa lakum. Assalamualaikum warahmatullahi wabarakatuh. Let's end our session with tasbih kafarah. Okay, assalamualaikum.
Thank you.
Assalam. Thank you, Doctor.
Thank you, Dr.